Welcome everybody. I'm Meg Bruning. I'm an associate professor at Arizona State University and the director of a Maternal Child Health Bureau funded program on maternal child health nutrition. And we have a seminar series, and we're really glad to have Dr. Valerie Bluebird Jernigan with us today. She's a professor at the University of Oklahoma Health Sciences Center's College of Public Health, as well as the executive director for the Oklahoma State University Center for Indigenous Health Research and Policy. She earned her doctoral degree in public health from the University of California, Berkeley, and also completed her postdoctoral fellowship in cardiovascular disease prevention at Stanford. Her research focuses on improving Indigenous food environments through policy and systems interventions. So today she'll be talking to us about restoring Indigenous food systems to improve Native health. I just ask that you save your questions to the end, and I'll help facilitate that question and answer session. Dr. Jernigan, please take it away.
Hi, thank you, Dr. Bruning, and hello, everyone. Is the sound okay? Can you hear me?
We can hear you.
Okay, great. It's a privilege and an honor to be here. So thank you very much, Dr. Bruning, for inviting me. And as was said, I'm going to talk with you today about restoring Indigenous food systems to improve health in Indian country. And you can go to the next slide. My research is focused on community-based participatory research, and I do that at Oklahoma State University Center for Health Sciences. So let me go ahead and close out my email really quick so that you don't hear that beep. We're actually home to the first tribally affiliated medical school in the US, the Oklahoma State University College of Medicine at Cherokee Nation, which just launched this fall and welcomed its first incoming class. So I and my research team came to OSU last year when we launched our Center for Indigenous Health Research and Policy. And the three areas we focus on: reconnecting Indigenous people with our traditions and practices to promote health, education, and training. And as I said, participatory research, which we combine with action to improve the health of Native communities. Next slide. So I am an intervention scientist using CBPR to address cardiometabolic conditions, and I do so at multiple levels, including thinking about the contribution of the food system to these conditions. And this is a food system model I like. It's developed by Rutten and colleagues. I like it because it includes health outcomes. You'll see the different components of the food system, including the production and consumption components. And within those, you have subcomponents focused on food processing, distribution, food buying, and preparing. Today, I'm going to talk about two of our studies. Our Thrive convenience store study, which focused mostly on the consumption subsystem, but we did include elements of food processing and distribution. And I will also discuss the Fresh study, which focuses on the food environment, production, consumption, and nutrition components. Next slide. So to introduce the Thrive study, I'm starting here with a map of the tribal convenience stores in southeastern part of Oklahoma. And these are owned and operated by the Chickasaw Nation and the Choctaw Nation of Oklahoma. Here are some of the stores in Ada and in the town of Broken Bow, and you can see them a little more closely. But the red dots show where these stores are sort of located all across the southeastern part of the state. So the purpose of the Thrive study was to increase healthy food access by improving these tribal convenience stores. If you go to the next slide, the reason we chose to intervene at the convenience store level was based on a preliminary study that we did. We conducted a cross-sectional survey of 513 Native Americans, and we administered the USDA 6-item short form household food security survey. We found 58% of natives that we surveyed were food insecure. And among those who were food insecure, the prevalence of diabetes, obesity, and hypertension was higher compared to those who were food secure, even after we adjusted for age, gender, education, income, and study site. We also found more than 60% of natives surveyed reported shopping for food at these tribal convenience stores 3 or more times per week. So one of the tenets of CBPR, participatory research, is to start where the people are. So we knew that whether or not these tribes had intended that those convenience stores serve as grocery stores for tribal citizens, they were in fact serving that purpose. And so this would be the place where we could actually potentially intervene with Native community members. Next slide. You can see a little bit more closely this food system conceptual model that drives a lot of our work. And this time it's a little bit bigger, but the focus of Thrive was, as I said, primarily in that consumer subsystem. And that includes the way that people acquire and prepare and eat food, but we also focused on distribution. When we think about food distribution, it's really vital to people acquiring foods. When you have failures in the distribution of food, like we see right now with COVID, through all the appropriate channels, you see food insecurity and food deserts. And so communities like the communities we intervened in the Thrive study, where you have few or no supermarkets offering healthy options, are just some examples that really put up barriers to folks affording healthy foods. Next slide. So the design and the methods of the Thrive study are published, and they are guided from the Institute of Medicine's recommendations for preventing childhood obesity, and we were guided also by Centers for Disease Control and Prevention's recommended strategies for obesity prevention. We did a participatory research study cluster control trial with 8 stores, 4 intervention and 4 control stores. And we followed a longitudinal cohort with about 1,637 Native shoppers, and we surveyed them before and after the intervention. Our intervention strategies were what we call the 4 Ps: product, placement, promotion, and pricing. And when I talk about specific intervention components and data, I moved to talking about Nation A and Nation B per Tribal Institutional Review Board preference, just to protect the data. And so Nation A, they did a 9-month study, and it started in July of 2016 and ended in April 2017. And Nation B did a 12-month study, and it started June 2016 and went through May of 2017. So the differences in the lengths of the intervention just really were based on what the different tribal nations were able to do, what was feasible for them. For our outcomes, we looked at both store and individual level outcomes. At the store level, we looked at increased fruit and vegetable availability. We did this by assessing store inventory and sales, nutrition environment measure scores. At the individual level, we looked at increased fruit and vegetable purchasing and intake. And we looked at eating behavior, self-efficacy, perceived nutrition environment, sociodemographics, and exposure to the intervention. We were hypothesizing a dose response. So exposure to the intervention, the more times someone shops at the store, the more they're exposed to the 4 Ps, the different strategies we were using to intervene, the more likely they are to change their purchasing and eating behaviors. Next slide. Our study was implemented in 2 phases. First phase focused solely on product. So the 4 Ps, we really started with product. And this was to develop a baseline of what actually existed in the stores in terms of product. And so we had to go in each of the stores and calculate their nutritional value and assign each store a nutrition environment score, which I referenced in the previous slide. To do this, we adapted and validated, I don't know if you've heard of it, but it's the Nutrition Environment Measures Survey. And we adapted that for use in these tribal stores. And we determined from that a baseline score and what possible foods met our healthy criteria. So of the foods that were available in that store or that they had access to from their vendors and distributors, which of those foods met our criteria? Our healthy food criteria were both for snacks and for meals. Those were two focus areas. For snacks, 300 calories or less, 30% fat or less. For meals, 500 calories or less, and both focused low in sodium. We came up with a list of foods that were available to be ordered by the existing food vendors, and we determined we needed a minimum of 5 snacks and 3 meal options to provide enough diversity. Next slide. Phase 2 focused on intervention strategies, and those included the remaining 3 Ps: placement, promotion, and pricing. And we really had to determine at this point, based on the potential food lists that we now had, which foods were prioritized by the communities. And so we did taste tests, we examined product placement and promotion testing, and we did price testing. So for all of these, we held community focus groups. We, had clicker polls, so we would survey folks in real time. Their results would be shown up on a screen, and then we would ask them, questions around what they liked in terms of the promotion materials, which foods that they liked, how much would they pay for those foods, so on and so forth. Next slide. So here are some of the products that were developed as part of the intervention. In this particular tribe, we could not find enough healthy food available to actually order from existing vendors. So what this tribe chose to do was to remodel the space in some of their most rural stores, which are the ones that had problems getting the food from the vendors, and to actually order the foods from grocery store suppliers and package them in-house. And so these are examples of 2 of the meals that this tribe put together: a salad meal and a wrap meal. And so they really invested a lot in creating some major changes within their stores to be able to change up their offerings. Next slide. We intervened on placement. So we remodeled various aspects of the store to determine the best placement. And here's an example of before and after layout changes. So on the left, you see the store layout before. You have a hot box next to the entrance and next to the cash registers. A hot box is where fried and ready to go foods are kept. And the rest of it is mostly packaged foods that are in white. If you look at store layout after the intervention on the right, you can see the intervention foods in red. And so we replaced the hot boxes with large walk-around coolers for each of the stores. And we put the hot boxes behind the cash registers. And we stacked the intervention foods in those places of high traffic at the ends of aisles and all around the cash register, and all within the large walk around cooler. Next slide. For promotion, we translated a lot of phrasing into native languages. We changed signs, And we posted the signs around in the strategic locations to promote the healthier options. And these are just some examples of the promotion strategies. And the next slide, strategy number 4 is price. And so price is something that folks often ask about, and this was an interesting aspect of the study. We planned to augment the cost of the foods and support the tribal stores. If the foods didn't sell, we would reimburse the stores any losses that they would have with some funds from the grant. And this was our agreement with the tribal stores. However, the first month of the intervention, the tribal stores wanted to establish a baseline price for the foods, and because most of them were newer foods, new food options, and offerings that hadn't been offered before. So they wanted to price the foods at the suggested retail price and then change them after a month. However, we found that the price of the foods was appropriate according to the tribal stores because the foods were selling out so quickly. And so they kept at the suggested retail price, and we never had to cover any losses. In fact, many of the foods sold out and continued to sold out, so they had to change their amounts of ordering. Next slide. So the findings and sustainability, because I'm presenting 2 studies, I sort of give you the very quick summary on this, but you can go to our publication, American Journal of Public Health, and you can read more about what we found. To summarize, the intervention increased healthy food options, both perceived and objective. Nutrition and environment measure scores increased. So this is a big win for us in that we go to tribal leadership with this information that we were able to objectively improve the stores and that people noticed. And this is one of the big factors that led to the tribes deciding to implement these intervention strategies for permanent policies. The study also increased purchasing of healthy foods, and it increased self-report of healthy food intake. However, like other studies that intervene purely at the environmental level, we did not see any significant changes in overall dietary intake, but we did change purchasing decisions, especially among those shopping more often. And as I said, the strategies that we implemented became permanent for both of the tribes. And so our next step with this study, we actually have we actually have 2 studies in place that we're just starting now. And one of them is to expand the intervention strategies and include behavioral change components. We also hope to offer more traditional foods and increase local food options. So that's the plan going forward with the Thrive 2 study. We also have a food pharmacy study that we're starting, and that study is to support local food boxes in the pharmacy environments of one of these tribes so that we can see if a food pharmacy, food is medicine intervention is efficacious. So that is the Thrive study. And I'll move to share with you now the FRESH study. The FRESH study is a CBPR partnership with Osage Nation. It began probably, I would say, in 2014, 2015. And it was initiated by Osage Nation. They had built a farm, Bird Creek Farm, and started this farm initiative. And they did this to promote Indigenous food sovereignty. As the chief of Osage Nation and assistant chief said, finally, we have a way to do what we did 200 years ago, feed our own people. So their goal really was to create a sustainable food system for Osage people. Next slide. Indigenous food sovereignty is often defined as an orientation to our relationship with the land that emphasizes our right and responsibility to healthy and culturally appropriate food produced through traditional practices. It is an orientation that supports us in taking greater control over our food systems by increasing traditional and healthy food access and helping us reduce our dependency on packaged foods. And it's really similar to public health efforts in other communities that try to address food systems changes. And so this is an indigenous model of wellness, which is really being called for right now, to use indigenous models of wellness to promote health. And so this is one that we're testing now. Next slide. So tribal leadership had this goal to create a sustainable food system, and they suspected that such efforts would also lead to improved health among Osage citizens. So they asked our center to create a study that might assess the impact of this new farm on tribal health. And so that's what our focus was, to develop the FRESH study. It's a culturally relevant, multi-component, multi-level farm-to-school intervention. The focus is to increase fruit and vegetable intake among Native children and disseminate findings to assist other tribes in improving their own food systems and thereby improving health. Next slide. This was a waitlist control trial with 4 communities as the unit of randomization, with a total of 9 early childhood education centers, ECEs, across these communities. The inclusion criteria: you had to be American Indian, have a child aged 3 to 5 enrolled in one of the ECEs, live on the reservation, and have no plans of moving within the next year. The intervention was implemented in 2018 with 2 communities, or 5 early child care education centers randomized to receive the intervention first in the spring of 2018, and the other 2 communities got it the following fall in 2018. The intervention itself was 15 weeks with a total of 369 participants, 176 parent caregivers, and 193 children. Unfortunately, due to the small enrollment size of these ECEs during this particular year, we were underpowered for this study, which is one of the challenges of doing research with Native communities, where our sample sizes are often limited. And we were looking primarily at increased fruit and vegetable consumption with willingness to try in these very young kids as one indicator of change. We also looked at some outcomes among the adult parent caregivers, including food insecurity, vegetable and fruit consumption, BMI, and blood pressure. Next slide. So at the multiple levels, obviously we have the farm at the environment and policy levels. At the school and community level, there were menu changes, a staff feeding program, and a curriculum implemented. And at the family level, we did a passive intervention, weekly meal kits, web-based parent curriculum, monthly family nights. So the next slide goes into a little bit more depth about what these curriculum components and levels of intervention entailed. And we've started to publish on this study. We're just now getting some pubs out. And so far, they're mostly descriptive of the intervention and the curriculum. So at the child level, the children were provided a sensory, gardening, cooking, and culturally healthy eating curriculum. And they received take-home recipe kits each week with fresh produce provided from Bird Creek Farm. The teachers participated in several workshops to co-develop the curriculum with us and develop it and deliver it within the classroom. They were provided with all the supplies they needed, and we also built demonstration gardens at each ECE so they could teach the curriculum with these gardens. We created the ECE menus, and we created actually a best practice menu that incorporated Bird Creek Farm produce. And this reduced pre-fried foods and provided 4 to 5 additional servings of vegetables per week. For the parents, we didn't directly intervene, as I said, on their dietary intake, but we did offer a series of brief web-based videos that included tips and strategies on encouraging vegetable and fruit consumption among their children. We also held 4 in-person monthly traditional foods, cooking, healthy eating, and food sovereignty workshops. And we cooked traditional Osage food, as well as discussed at these meetings the relationship between the food system and health. Next slide. So in terms of data collection, for the children, we looked at a couple of measures. It's pretty hard to collect dietary measures with kids. So we had to rely a lot on our nutritional epidemiologist for some of these measures. So for the children, we looked at willingness to try the vegetables and fruits, and we looked at plate waste before, during, and after the intervention. And we examined fidelity to the classroom intervention and menu with weekly surveys and site visits. So that's how we really monitored the intervention. And for the parents, we assessed diet using 24-hour dietary recalls. We administered surveys, and we collected biometric data before and after the intervention. Next slide. So our findings, and I like this garden slide, just the one before this, because these are the garden beds. And I just like to point out, you know, we were really hands-on with this. We built these beds. We worked with tribal community members to do it. We strategically placed the beds, you know, next to all of the ECEs. And the children really had an amazing time, and the curriculum allowed for them to really go out a lot and develop, you know, experience the sensory component of the curriculum, and they loved it. So as the tribal assistant chief said, he said, we are looking forward to knowing the study results, but we also don't really need to know, because we can tell you right now that this is done more for the community in terms of encouraging healthy eating than any other intervention we've seen. And it really did introduce children in a reservation setting whose parents hadn't necessarily had access to fresh produce during their childhoods, to, you know, fresh produce that they otherwise might not have been exposed to. So just that part alone has been a pretty huge, you know, achievement for us. Next slide. So these are the child willingness to try findings. And as I said, it's a way to assess changes in dietary intake, dietary behavior among the really young children. So trained observers rated each child's interaction with each vegetable using the Farfan-Ramirez checklist. It's a checklist that has rating options ranging from 0, where the child doesn't even touch the food, all the way to 4, where the child eats the food. And based on this scale, a total score was calculated by adding the observer ratings 0 to 4 for each of the 6 intervention vegetables in our curriculum, which were the 3 sisters: corn, beans, and squash, and as well as tomatoes, spinach, and peppers. So there's a total possible score of 0 to 24 for all 6 of the vegetables. And as you can see, total willingness to try scores were improved in both groups. Next slide. And this is child plate waste. Child plate waste provides each child with a numbered plate and with pre-weighed servings, and allows us to objectively measure their consumption. there was a significant improvement in total vegetable intake in beans, squash, corn, spinach, tomatoes, and pepper. Specifically, we did see an improvement in beans and squash in the intervention group when we compared to the control group pre versus post. Next slide. These are the caregiver demographics, and you can see the mean age is about 33 years. Most were female. For about 45%, the highest level of education was a high school diploma. Over 2/3 made less than $50,000 in combined household income, and most were employed full or part-time. Most were also married. Almost 1/3 of those we surveyed received WIC benefits as well. And there were no significant differences between the control and intervention groups for these demographics. Okay. This is self-reported vegetable and fruit at baseline and follow-up for the caregivers. And for parent caregivers, their self-report of dietary fruit and vegetable intake, though we didn't really intervene directly on their diets, we did see a trend towards higher intake of fruits and vegetables. This is actually cups per day. Okay, next slide. This is self-reported food insecurity at baseline and follow-up in caregivers. Food insecurity reduced quite a bit. The mean food insecurity score improved, and fewer caregivers reported experiencing food insecurity at follow-up in both the intervention and control groups. So about 35% versus 21.5%, and 43.8% versus 29.4%. So there was about a 13% reduction in food insecurity that we saw. And since there wasn't anything else happening that was significant in the community at that time, we hypothesized that it might just be that the farm was actually contributing to reduced food insecurity, as there was a lot of surplus food at the farm, and we gave it away each week at the end of the week to the families, but the farm was also distributing food as well. And so overall, we saw reduced food insecurity among the parents. Next slide. We also saw moderate and total physical activity were significantly higher among the intervention group at follow-up compared to control. And this surprised us because we didn't really intervene on physical activity. Obesity and high blood pressure decreased slightly in the intervention group from baseline to follow-up, while increased in control. That was not significant though. Next slide. So these are just some pictures of our classrooms with the kids and the foods that were dropped off and prepared by the cooks at the ECEs. And the kids really, really enjoyed this and really loved it. And we were really happily surprised at how easy the cooks reported the integration of fresh produce was into their daily activities and their meal plans. So this is the last slide, and so I'm looking forward to taking your questions. But to summarize, we did achieve our launching of the Bird Creek Farm as we'd hoped, and its continued development. So we actually have tripled active usage of acres and food production at Bird Creek Farm. And we've used our data to advocate for policy. And Bird Creek Farm was expanded by Osage Nation Congress in 2019. They got more staff. They got a lot more staff positions. And they also made the menu changes in the ECEs permanent. And we developed and disseminated the findings as part of a documentary, Blood Sugar Rising, which just premiered on PBS in April. And it features some of this work. A lot of the findings were still being analyzed, but it shares the process and the CBPR nature of the work, which that was also featured in the journal Nature as well. We've had a lot of press coverage with this in terms of for public health intervention. People have been very interested in this. And I think one of the main reasons is because food is so central to health outcomes, and it's especially important in Native communities. And yet so few interventions in public health incorporate food system change. You may find delivery of meals, you may find, food is medicine interventions, but you don't do anything to ensure sustainability. And with a farm intervention like this, or our next plan, which is a community-supported agriculture intervention, you really put in place the long-term community supports that you need to continue the efforts long after grant funding is gone. So both our studies were funded by National Institutes of Health. The Thrive study was funded by NHLBI, and National Institute on Minority Health and Health Disparities has funded the FRESH study. And I look forward to taking your questions. Thank you. Oh, sorry, you're muted, Meg.
Yeah, thanks so much for a wonderful talk. We're happy to take some questions now. So if you want to raise your hand, and then I can allow you to talk. And hold on, sorry, this is a lot to manage. All right. Yes. There's some positive feedback from audience members. Excellent. All right. Be patient with me. This is the first time. Sure. All right. Kim, I'll let you talk. Kim?
Hi. Yes. Hi. Yes. I was wondering if you experienced any pushback with any of the interventions that were going on, either from outside or within the community.
Both of the interventions, definitely we didn't receive any pushback. For the Thrive study, we had done so much work on the front end to encourage tribal leadership because it was really an environmental change. So we really wanted tribal leadership to be on board, really support the interventions. We didn't want there to be any friction or, really any challenges with regards to, having access to the stores. So with that one, we spent about 2 years in development of the study with tribal leadership and tribal health planners to really co-develop the study and emphasize that we weren't taking any foods out. We were just adding foods. And the publication that I haven't cited yet that just came out, I think 2 weeks ago, is our sales data manuscript, which shows, because the tribes give us full access to all their sales. And it shows that not only did the foods, the healthy foods not reduce sales in both tribes, but they actually increased sales and revenue. So we didn't get any pushback with the Thrive study or with from leadership or from community members. With the FRESH study, we also spent a lot of time. That one we were specifically asked to develop a study on this particular topic. And we did have some lessons learned that were really important going in. For one thing, in the Osage Nation, with Osage people, the role of a cook, we were taught, is a highly regarded role. And so it was important that, you know, the cook that cook role be really guiding us. And so we didn't know that at first. And we were told that, we learned that, and then we quickly had a number of Osage cooks help us and guide us. And one challenge that we encountered was that when we would do our healthy foods nights, we presented some of the recipes from Sean Sherman's book, and we also presented some other very traditional recipes. And we were told by community members, these are great, they're wonderful, but we need foods that we can access and eat really quickly and easily for most nights, because some of the practices that go into preparing really traditional foods, you know, you can't always do those when you come home late and you have a number of kids to feed and you're both working, and you need to be able to purchase foods quickly and easily from the local grocery store. And so while harvesting and foraging and hunting, you know, and fishing might be great traditional practices, we can't always do these every day. And so we had to be really sensitive around presenting foods that were traditional, but also were realistic to prepare and affordable to prepare, and walking a real delicate balance with that. So that's one of the challenges. But in general, you know, we always try to adapt and modify the study with feedback. So we're not the kind of researchers that would prioritize the data over community needs and feasibility. We had a lot of conversations around how long the curriculum took to deliver in the classrooms. It took 90 minutes, but should it be delivered in one chunk, or should it be delivered across multiple days? All of those kinds of factors were left up to the individual classroom teachers, because they had multi-age classrooms, and it just depended on what they could do and what they felt was most feasible. So those were the kinds of adaptations that we always wanted to make. You don't ever want to leave a community having had a bad experience. Research itself needs to be uplifting and capacity building, and not something that's, you know, draining and unrealistic. So that's what we strive for. I hope that answers your question.
We have another question from Chris, who echoes what a fantastic presentation. Chris asks if there are any materials you develop for the fresh intervention, such as the culturally relevant curriculum, the menus, workshops, that are available for other tribes to use as a model for their own intervention.
We're trying to get those pulled together right now, and absolutely we will publish those and share those. I think some of the menu changes description, I think, is out. It's been published now. But as far as the classroom curriculum, that one's in preparation right now. And some of the other ones, this was such a huge study, had so many components, that it became a little bit difficult for us to figure out how to tell this overarching story with the multiple components that we had in the study. And it was like, well, the curriculum itself should be its own paper. You know, we can't. And so we've had a struggle of how do we tell this whole story without going into much detail and then creating little papers from the details of it? So it's been kind of challenging for us, and we're doing that now.
Awesome. Keep us posted, and then we can disseminate to the attendees.
Yes, I will.
Are there other questions? I can ask one if there's while we're waiting. So I'm curious with COVID, what sort of adaptations or what is the community asking for now? You mentioned a CSA project. Is that a CBPR project as well, or are you working on some additional things?
That's definitely a CBPR study. One of the things about CBPR that is really, it's a big kind of part of it, is committing long-term to the goals and priorities of a community. And so as a researcher, in reality, we can only do so many of these studies because of the time it takes. Most of these partnerships that we have with communities, they tend to last probably upwards of 8, sometimes 10 years. And that's the amount of commitment it takes to really do a CBPR study that has any kind of impact. I mean, some have impacts quickly, but one that builds long-term sustainability, that takes a lot of time, and that intervenes at systems levels. That's also key to us. So we've really focused on, choosing partnerships that we value the goals that the communities have and stand, with them in their community goals. And that's kind of been what we've focused on. The COVID has really impacted the way that we do our research, because we haven't been able to be working really, really closely with communities and community meetings. We've had to do Zoom meetings, and that's been really challenging. We were post data collection with the FRESH study, so that didn't impact any of our data collection. We have other studies that it has, but it's mostly impacted our ability to engage in a lot of planning work. We're continuing to really want to focus at the deepest, kind of levels of systems change, and when working within that food system itself. So that's what they want, and that's also what we want. So it's a really good match.
Thank you. Savannah asks, personally, do you envision the farm becoming part of all tribal nation curriculum in the future?
Do I envision the farm becoming part of all tribal nation curriculum in the future? In that particular community you're asking? Is that what you mean?
I'm wondering if this is a dissemination question, and do you think that this could be replicated as part of all other tribes?
Sure. We definitely have seen this farm expand within Osage Nation and do a lot of, it's not just farm to school, but it's now, going to be in other programs, and it's going to develop into a CSA. And I do think that this kind of model of reclaiming the land for food production is something that is critical to Indigenous food sovereignty, something that National Congress of American Indians has prioritized with their new Tribal Food Sovereignty Initiative. And it's something that folks are really interested in at policy levels. How do you exercise sovereignty and food sovereignty being part of that? Are there strategies that you can undertake to support that? And it's different for every Native nation, because every Native nation is different. And it's different for natives living in urban areas. So how does it work there? Those are the questions within the field. I think the big question within, the two pressing questions within this field would be, from my vantage point, there's a huge call for Indigenous models of wellness to be used in Native interventions, rather than taking Western models and pulling them off the shelf and adapting them for Native communities. Can we use Native ideas of wellness, Native models and concepts of wellness to drive our public health programming and our intervention work? This is an example of an Indigenous model. It's grounded in relationship to the land. It's grounded in sacred responsibilities we have with the land. And it's grounded in the idea that when you repair connections to the land, you actually heal and the health of your community improves. And so we now have to, as public health researchers, find out if those interventions are in fact as efficacious as Western interventions, quote unquote, or indeed more efficacious, which is what we are hypothesizing. And how do we assess that in ways that capture all the variables that are important to Native communities? Because they might not just be changes in blood pressure, but they might be children learning the names of foods within their own languages. They might be, other measures. So as scientists, that's our next step, is not only do we need these Indigenous models that can drive interventions in public health programming, we also need to get the right variables and ask the right questions to assess their impacts.
Thank you. Savannah, I hope that answered your question, or if I captured your question appropriately. If we didn't, please just reframe and ask it again. Kim has another question. Since the introduction of produce in the Thrive study, do tribal stores accept SNAP or WIC as a form of payment?
I know, that's a great question. It was thought about when we were working on that study. And it was something that one of the tribal nations was really, really strongly considering. You probably are aware that in order to be able to accept SNAP or WIC, you have to, be able to carry the range of food that they require you to carry to be, qualified as one of those stores. There were challenges for them doing that they were examining at the time that the study ended. It actually just ended officially in May of this year, 2020. It's like, what year are we in? It's COVID time. I don't remember. So at that point internally, there were discussions, and we as scientists weren't privy to those discussions. But it was definitely shared with us that that could now be an option if they expanded the stores to include, these new various products, and shown that that consumers do purchase here frequently and they will buy healthier foods here if they're offered, is a logical next step to become one of these other certified stores. But I don't know all the barriers and all the challenges and things that they're considering to do that. But I will follow up, because I'm still also curious about that.
Especially given your impact on food insecurity in your other study as well. Yeah. Deetria, I'm sorry, I hope I said that correctly. She loves the idea of having garden beds set around ECEs. Is there a component that encourages family to grow their own food at their own homes?
We didn't have that component, but it definitely became something that the parent caregivers started to do. And they they started to actually use the garden beds at the schools. So they continue to do some of the growing and gardening with their kids because they, you know, lived nearby the schools and could access it, and they were open. We didn't encourage that, but that was something that community, the parent caregivers did express. Definitely is a focus as part of the farm. You can actually participate in the growing. We go there every week and volunteer just because it's good for our mental health and our staff. Like we really enjoy it. We've gotten really into it. So we're all in with it, and it's changed our lives for sure. I started a garden after this, and I did it because one of the tenets of Indigenous food sovereignty in decolonization is actually being in right relationship with the land. And it's actually, you have to actively, Indigenous food sovereignty is an active practice, and it entails actively engaging with the land. And so it's part of my own personal philosophy I've adopted as a public health practitioner, as well as a Native person. So I think this is a great example of how CBPR, when done right and done as it's supposed to be, is a co-learning process. We get to learn so much by staying in partnership with communities and working on these projects. It's not just a delivery of something that goes into the community because they're the ones that need it. We all need it.
Very moving response. And thank you, Valerie, so much for your time and sharing your research. And I just want to make sure there's no more questions, but as we really appreciate your time, and please keep us posted on your work so we can help disseminate it on our end as well. Just a heads up for the attendees, we're switching gears for our next talk quite a bit. We have Jessica Alvarez from Emory University who's talking about cystic fibrosis and rethinking nutrition care for lifelong health. So we are a translational group talking about all areas of maternal child health across the translational spectrum, especially this important community-based work. So thank you all for joining us. Thank you, Dr. Jernigan, and take care, everyone. Stay safe.
Thank you. Bye.